Good afternoon, everyone. My name's Daniel Kramer. I am stepping in here for Heather Sorella, our ECHO facilitator. I'll be doing the ECHO facilitation today for our session 11 with Dr. Priscila Rodrigues Armijo. Priscilla, if you would advance the slide. So we welcome you today to our 11th session of University of Nebraska Medical Center Specialty Care ECHO, which will be focusing on cultural competency. Today's didactic presenter is Dr. Priscila Rodrigues Armijo. Dr. Priscila Rodrigues Armijo is a physician scientist dedicated to addressing health disparities, particularly among patients with limited English proficiency. She currently serves as an assistant professor in internal medicine at the University of Nebraska Medical Center and holds the roles of Director of Campus Engagement and Academic Affairs and Associate Director for Workforce Development at the Fred and Pamela Buffett Cancer Center. Additionally, she is completing her PhD at UNMC, where her work focuses on improving patient care through advanced training in communication and situational awareness alongside implementing clinical strategies to strengthen patient safety. I will be facilitating the ECHO today. Again, my name is Daniel Kramer. And then just quick reminder, sessions are the first Thursday of every month. Next slide, please. Just a quick disclosure here. Our HIV ECHO project is made possible through grant funding from ViiV Healthcare and is a sub-project of our I Am Capable project. Next slide. So for our ECHO agenda today for session 11, Dr. Priscila Rodrigues Armijo will be presenting us with didactic information regarding cultural competency and language access to help improve our knowledge on culturally responsive and language inclusive care. And then we'll have announcements to be shared at the end with a feedback survey link included in the chat. Next slide, please. And then we will be doing a brief ECHO after hours today. For our experts, Dr. Fiddle, myself, perhaps, will be here after hours for any extra questions, if you have any after today's presentation. Next slide, please. And then some housekeeping reminders here before we get started. We love discussion. Feel free to use the chat. And then there will be some time later on in the presentation where we will have some discussion where you can come off mic. Please make sure you stay muted unless you're speaking. Always welcome to turn on the camera. We love to see your faces. We are recording today's session. There will be a link available later on. And then, like I said earlier, at the end of the session, surveys will be available. And next slide, please. And with that, I will hand it over to Dr. Priscila Rodrigues Armijo. We're very excited to have her today. Dr. Rodrigues Armijo.
Hello, good afternoon, everyone. Thank you so much for the kind introduction and for the opportunity to talk with you today. As Daniel mentioned, we will be talking about cultural competency and language access in healthcare. So these are the objectives for today's sessions. We'll talk about briefly some definitions related to cultural competency terms. We'll define limited English proficiency and explore what is that role in patient outcomes, and explore some strategies that hopefully all of you can take home with you and apply in your jobs. So I will try to make this as interactive as possible. So if you could please take a moment and either use your own computer or cell phone that you have as you watch this session and log in into this poll everywhere. We'll have some questions throughout the session. And the first one is truly just to make sure you all have access to this. So I'll give you one more minute to make sure you all either join by the website, either looking using your camera and the QR code, or texting HIV ECHO to 22333. So if you've done that, you'll see that the first question would be, what is your primary professional role? So if you can please reply to that answer, and hopefully we'll start seeing some of the responses coming up. Okay, yeah, I guess that's working. That's good. Thank you all for engaging and replying. Just one more minute. So there are several epidemiologists, health educators, nurses, physicians, and other roles here in ECHO. So thank you so much for answering the question. Okay, some healthcare medical administrative personnel. Thank you. Yes, okay, hopefully this keeps working. Okay, so today we'll talk about cultural competency, but before I wanted to touch briefly about the social determinants of health. You've probably seen this graph before. So this is a graph by the Department of Health and Human Services. And as you can see, they have 5 main buckets that are about the social determinants of health, meaning factors that are inherent to oneself, culture, or background that could impact or determine their health outcome. And for today's sessions, we'll focus on 2 of those. So here on the top right, you can see the education access and quality. We'll focus on the language and literacy, as well as in the healthcare access and quality. We'll focus on the access to those health services, access to primary care, and health literacy. So we have another question, and now we're going to start. So if you could please, when you think about culture, what is one word that comes to mind when you think about culture? So if you can put please that in the answers. And if you just joined us, if you could please take a minute and just scan this QR code or join the web through this link here, and if you could provide your answers. So what is one word that comes to mind when you think of culture? So belonging, values, diverse, yes. Family, identity, us. Heritage, unique, lifestyle. Identity, family, yeah. So you are all correct. Thank you for sharing. So what is culture? It's exactly about a shared patterns of human behavior that includes all of the answers that you put in the answer, in the question. So it's a set of languages, thoughts, values, actions, identities, and material objects that define this pattern of human behavior. So what's really, really important is that culture is multifactorial. So you all shared great examples of what culture means, but it's also dynamic and fluid. So you can change how you identify your culture based off those factors as you grow up, as you meet new people. And definitely it's inherent to the individuals, right? So, diving deep into some of the terminologies and some of the terms you probably have heard of. So, cultural awareness is the fact that you are aware and you recognize that other cultures exist. So, you recognize that people come from various cultures, that those cultures can be similar and different from yours and from other cultures. You recognize that the experiences that one person has is shaped by their own culture and their background, and you also are aware that culture can impact how people understand and behave. Cultural sensitivity is when you are aware of different cultures, so you have cultural awareness, and you are not assigning a value to that culture. So, for instance, you're not saying that the culture is positive or negative, is better or worse. So there is the scale that you've probably seen before, which is the Bennett scales of intercultural sensitivity. And it's basically defining the stages of cultural sensitivity. So starting from your far left, denial is when you have no cultural awareness. You are not aware that other cultures exist. So your own culture is the only cultural background possible. When you progress to defense, you acknowledge that other cultures exist, but you have no sensitivity. So you're still assigning probably that value that your culture is the best or is a positive versus someone else's was negative. The minimization is when you start developing some of that cultural sensitivity and you start assigning some values to some pieces of the culture, but other ones you're understanding more of those differences that exist. Acceptance is when you move from this ethnocentric, meaning that you have your own culture, to the ethnocentric pattern where you now have full cultural awareness and you're starting to accept that those cultural differences and similarities, they're all positive and you start acknowledging them. So further you adapt, meaning now you are not only aware in your sensitivity, you have cultural sensitivity that there is no good or worse or good or bad, and you're also adapting to ensure that the other is feeling also welcome, that they belong. And finally, integration. It's different that you're not losing your culture, you're not changing your culture based on someone else's, but you're integrating everyone's cultures to make sure that you're having the best relationship possible. And finally, cultural humility. That's when you have your own internal process of self reflection. And this is usually an ongoing and lifelong process to really reflect about your own cultural awareness, your own cultural sensitivity. So that's when you are actively thinking about your own biases and how much, where in that scale you are at the term, at specific point in your life. So what about cultural competency? That's actually, the title of the talk. Cultural competency is pretty much gaining the skills and knowledges on all of those cultural terminology that we just discussed. So it's the process of gaining those skills to be culturally aware, culturally sensitive, cultural humility over time. So it's when you acknowledge those cultures from other people and you respect those differences and you minimize any of those consequences that could be negative or detrimental. And this is important in healthcare because we have patients who are culturally and or linguistically diverse, meaning that they are from cultures or backgrounds that it's different from the providers who are caring for them. And this is what we call culturally responsive care, is when the provider is intentionally aware, sensitive, and is leveraging this cultural humility process to really provide the best care possible that is individualized to that specific patient that they are seeing at that moment. So I really like this diagram that was published by Escobedo et al. And this was actually focusing on Latinos only, but I think it's really a good visual that help us understand how those factors, culturally, linguistic, immigration status, social needs, and faiths, how they can affect how they trust or perceive the relationship with their healthcare providers, causing emotional distress. And here on the bottom with this green arrow, you can see some of the components that we could do to ensure that we're having or providing culturally responsive care. And we'll go into details about those strategies later in the presentation. So here I would like to focus specifically on the language piece. So briefly defining what limited English proficiency is. So it is defined as the limited ability to read, write, speak, or understand English when English is not your primary language. And we're talking about limited English proficiency because we are in the United States. But honestly, this could be the same if you're in any other country. So for instance, if you're in Brazil, this would be limited Portuguese proficiency, right? You just replace that. So this is important because it affects directly how we provide culturally responsive care. So before we move forward, I have another question for you in the poll everywhere. So how often do you interact with people with limited English proficiency in your current role? So if you could please answer that, would you say that you interact with them on a daily basis, on a weekly basis, monthly? It's probably less frequent than that, or you never interact with people with limited English proficiency. And so majority of you, at least a third of you interact with people with limited English proficiency at a monthly basis. So 90% of you would have at least one encounter with a patient with limited English proficiency in your role. Thank you all for sharing. And this makes sense because if you look at the demographics of people with limited English proficiency, there are over 25 million people in the United States. And for patients specific with a diagnosis of HIV, 1 in 10 adults report limited English proficiency. So that's just supporting that. This is another graph that is specific to Nebraska. So looking at the non-English English language profile here in the state, over 12% of the households here in Nebraska report a language other than English as their primary spoken language at home. And here you can see a graph distribution from 2023 of the prevalence of the languages spoken here at state. And a very interesting fact is that the Nebraska Department of Education reported 118 languages that were identified amongst the students here in the state in the Omaha public schools. So now another question for you. Why do you think it is important to provide culturally responsive care specific to language and language access? So this is an open-ended question. Feel free to write as much or as little as you want. Brief answers would be just fine. Now let's see some of the responses. Respect, absolutely. To improve health outcomes, to build trust in your relationship with your patient. For informed consent, absolutely. To ensure understanding. To make the patient and the families and the relatives comfortable and ensure trust. So trust is definitely a theme because it is the right thing to do. I agree. Positive outcomes. So people know what they may have for health concerns, how to be treated and feel accepted. Without it, you cannot have true shared decision making. Yes, patient satisfaction absolutely is another metric. Yes, it's humane mandate to include patient in their care. Thank you all for sharing this. You're all absolutely right. And we'll actually talk about many of these factors as we progress in this presentation. So, yes, you mentioned about health outcomes. Absolutely. Patients with limited English proficiency, they are known to have worse outcomes than their English-speaking counterparts. So they are 3 times more likely to have unresolved medical issues, meaning that they either have a misdiagnosis or they go home and don't adhere to medications. They are 2 times more likely to have scheduling challenges because we know that it's not only about when you treat the patient in the hospital or in the clinic, but it's also what happens when they go home and now they have to fill out their prescription at the pharmacy, for instance, or to schedule their follow-up appointment. Again, 1.4 times more likely to be non-adhering to treatment, 60% less access to pain control. So it takes longer for them to receive medications, for example, when they are admitted to the hospital. They have a high risk for inpatient mortality rates. They have delayed diagnosis and treatment, and that's detrimental to their care because, as you know, most of the disease processes, they're timely and early recognition can be decisive. And also they have higher rates of unplanned emergency room visits. What about patients with a diagnosis of HIV? So those are just some of the factors that are specific to patients with a diagnosis of HIV as it pertains to limited English proficiency outcomes. So patients with limited English proficiency that are men who have sex with other men, they have 46% lower odds of receiving HIV in screening. So that's almost half less the odds. There is hinder access to HIV healthcare services, and again, delay in HIV testing and diagnosis. So they end up identifying or diagnosing HIV later, much later in the disease progress and during their care. They are usually non-adherent. They have decreased rates of antiretroviral therapy adherence. They have increased stigma, and it's actually independently associated with higher HIV stigma. A multi-site study found that back in 2018. So what happened is the Title VI of Civil Rights. I'm not going to read the title, but it's just ensuring that you should provide care to those people, and it's the right care for the people with to receive culturally responsive care. So the Department of Health and Human Services launched this National Culturally and Linguistic Appropriate Services Standards, usually known as CLAS standards. Again, this was a mandate by the Office of Minority Health back in the 2000s, and it's a blueprint of 15 national standards that everyone should follow. The goal is to really improve the quality and reduce those disparities that are seen by patients as it pertains to their culture and their language. So this is important because this is to ensure that we are providing care and services that are respectable and responsive to everyone's and individuals' cultures, health beliefs, practices, languages, literacy levels, etc. So this is another way of saying it's to ensure that the care we provide is culturally competent, that we have awareness, that we are ensuring that we have cultural humility throughout our career. So there are 4 standards, and here you can see them underscored. And for today's presentation, we're actually focusing on the Communication Language Assistance Standard, which pertains to standards 5 to 8. Is to ensure that qualified interpreters, translated materials, and clear language access services exist at healthcare institutions. So what about language discordant encounters? So this is pretty much when the patient and provider do not speak the same language. So here, a good distinction to make is between interpreters and translators. So interpreters is when you have someone who is doing the interpretation of spoken and sign or sign language messages, meaning that person is trying to match your tone, your pace, some of the nonverbal cues that are included in any conversation. So that's when you have interpreters. Translators is when you're talking about reading messages. So for instance, now there's this hot topic of artificial intelligence as replacing or helping with interpretation, but actually they are helping with translation because they cannot mimic the pace, the tone, or the context, right, of the message. So AI would be an adjuvant for translation and not interpretation. But regardless, the purpose of both is to really facilitate that communication between the patient and the provider. So talking about interpreters, they are there to provide this communicative autonomy, meaning to ensure that the patient is responsible and in control of their own communication. They are not there to do what we call the cultural filtration, meaning that they are inserting their own biases or their own background into that conversation. So that is why usually we say that it's best practices to have a certified and someone who is actually trained interpreter to mediate that conversation between the patient and provider. Of course, there are challenges, and we know that some dialects, for instance, there's no interpreters available. Sometimes there's a timely diagnosis. But as a rule of thumb, we should not have children's relatives, even proficient providers, to provide that care if they don't have enough training on how to do so. And we could even actually give a talk on just about that moving forward, but let's just move with that. So in language discordant encounters, what can you as a provider do? And as a healthcare administrator as well, to allow for more time for those encounters. That's one. So that could either be before the encounter, before that interaction between the patient and provider, give time so the provider can talk with the interpreter and make sure that the interpreter knows what's happening, what's about to happen, give some, at least a summary of what you're going to discuss. Allow extra time for the visit itself, because it usually takes twice longer, right? Because you're having someone needing to interpret that conversation. So you should not allocate the same time for that encounter. Make sure that there are minimal distractions, so no phones, no pagers, ensuring respect for everyone. It's important for you as a provider to use always first person and speak directly to the patient. So usually you sit almost in a triangle, so you're actually looking at the patient and not looking at the interpreter, and using a simpler language, excuse me, and make sure that you understand those different communication styles. And if a patient denies language assistance, most of the healthcare institutes have waivers. So make sure that the patient signs the waiver, but not only signing the waiver, but ensuring that they understand why the provider understands why the patient is denying an interpreter. So what you should not do, patronize the patient or their family. You don't have to speak louder. You should not hold the interpreter accountable or responsible for any miscommunication. Not ask the interpreters to go beyond their scope of practice, and do not assume anything. For instance, do not assume health literacy, do not assume understanding. So make sure you're actively always asking for those. And do not use the patient to practice your second language. That's not the time for that. So now shifting to some strategies that you can hopefully take home and apply in your own job. So the language ID card is one of the simplest ones. It's usually readily available online. You can find several versions of those. This is just one of them here that we use in the Nebraska state. So basically, this is written that I speak language, and of course in their own language. So the patient can point to that language, and you can request the most appropriate interpreter for that interaction. Another one is the teach back method. And keep in mind that we're talking about the strategies as part of this providing culturally and linguistic access. But this could really be applied to any patient-provider communication that you have, even when you're speaking the same language. In fact, we encourage you to leverage those strategies for that purpose. So the teach and back method is when you share the information you need. So you have a new diagnosis of HIV, and now you need to discuss some of the treatment and how the patient should go about it. So you share that information in a clear and simpler manner. And then you ask the patient now to tell you exactly what you just told using their own words. So here we have some examples of how you could say, so I want to be sure we're on the same page. Could you tell me what I just explained about how you should use this? Or I want to make sure that it explains things clearly. Can you just explain to me what we just talked about? And then you listen. And if you realize that what they're telling you is probably inaccurate or incorrect, that's when you present the information again, but of course, rephrasing it, not the same way you did for the first time. And then you ask them to confirm that understanding by teaching you back what you just told them. And you just keep repeating the cycle. This is a very simple way that you could do at the end of your encounter to ensure shared understanding. The learn model is another one. So it stands for learn L is in listen. So you listen to the patient and you try to understand the patient's perceptions of the problem. And we'll talk about some of the strategies to do exactly that subsequently. You explain your perception as a provider of the problem. What is your perception? And then you acknowledge what are the differences and the similarities between the patient's perceptions and yours. And then finally, you recommend a treatment, and now you negotiate that treatment. So, how do you negotiate a treatment? It starts by acknowledging. So, it's kind of in the model itself. So, you acknowledge what is the perception of the patient, what is the most important piece for the patient, what is the priority for the patient in their treatment. And then you try again to explain your perceptions, and you have that positive discussion, right? About until you understand why they want to move forward with X, Y, or Z. So the Climate Aid questions is one way of ensuring that you are truly listening and trying to understand what is the patient's perception of their disease and what's going on. So you can read those questions, but it's pretty much asking what the patient thinks is the cause of the problem, why it started when it did, what do you think this is doing to you or affecting you, how severe it is. So you can ask any of these questions. And a better one is actually the revised Climans one, which is the PACT. It's just a simplified method. I think it's easier to remember. It's about PACT, problem, affecting, concern, and treatment. So what do you think the problem is? How is the problem affecting your life? What concerns you the most? And do you feel this treatment plan will help you? So this is a good way of really understanding comprehensively what the patient understands and thinks and expects, what their fears are about what's happening to them. Oh. And another one is the shared. This is really to ensure the shared decision making. So we need to make sure that you are conveying the message that the patient-provider relationship is equal. So it's a two-way, and you're coming up and you are defining the decisions on how to move forward based on both the providers and the patient's perspective and expertise. So you can seek your patient's participation and you help them explore and compare those treatment options, assessing again their values and their preferences, reaching that decision together and evaluating that decision as a team. And then finally, this is kind of a bonus. This is not only for, not specific to one patient-provider interactions, but for situations such as a pandemic happens, how can you apply those class standards during crisis communications? So it is really helpful to identify what are some of those cultural linguistic groups and community members. So are there any nonprofits that already have contact with those patient populations in the state or in your specific county? Leverage them or leverage the providers that care for those patients to really tailor the materials to their culture, the language, the level of the average level of literacy for that specific patient population that you serve. Leverage all of those class standards, strategies that we discussed. And again, ensure that you're using both verbal and written communication. And here, even signs could be helpful. And finally, work with those community partners to share that information because they're usually very trustworthy amongst their own communities. Lastly, we'll share with you at the end, after the session, some self-assessments that you can take. There are three. One you can take as a provider, as a healthcare provider, one that you can take as a staff member, and one that you can take on behalf of your organization. This is really helpful for you to have some, not only to assess what's happening and how you're providing culturally and linguistic care, also to identify some opportunities to improve the care you provide. So they're usually broken down into three main buckets. There are 37 questions in total for the primary healthcare one. And what you do is basically you go over each of the questions, replying A, B, or C in terms of how frequently you do that specific thing, that statement, or how that statement applies to you. So here I would like to go over one question for each of the main buckets. So you can all think about it together right now. So the first one, it's about the environment, materials, and resources. So I ensure that printed information disseminated by my agency or my program or my clinic takes into account the average literacy level of the individuals and family receiving services. So think about that. Do you think that the states applies to you to a great degree? So you do that frequently. You have those printed informations available. Do you do that occasionally for some situations? And for others, you could potentially develop those, or you rarely or never do that. And that's probably a great opportunity for you to start doing moving forward. That's one example. Another one is about communication styles. So think about when you interact with patients or families with limited English proficiency. Do you always keep in mind that LEP is in no way a reflection of their level of intellectual functioning? Do you keep in mind that their limited ability to speak in English has no bearing on their ability to communicate effectively in their own language of origin, in their native language? And do you always keep in mind that they may neither be literate in their language of origin nor in English? So their health literacy could be lower even in their own native language. So how often do you keep that in mind? And finally, your values and attitudes. So I avoid imposing values that may conflict or be inconsistent with those of cultures or ethnic groups other than my own. So just reflect for a moment. How often do you actually do that every time when you encounter patients or relatives or family members that have limited English proficiency? Okay, so now it's your turn. We do not have a specific case for today. However, I would like you to first reflect and think about a situation when you interacted with a patient with LEP. So you told me at the beginning of the presentation that you interact with patients with a limited English proficiency quite often, right? So think about a specific situation and reflect about what went well and what would you have done differently now that you know some of those strategies. And I would like to ask a few of you to please share with us, not necessarily that situation specifically, but the lesson. What is one thing that you think overall went well? What is one thing that you would have done differently based on what you know now? So if you could please unmute yourselves and just share with us.
Yes, would love to hear from you. And if you're not somebody who likes to talk, please feel free to share in the chat as well. But we would love to hear your voice if you'd like to share a case.
Or maybe, oh, go ahead.
I'll throw something out there. This is something I guess I would just ask for some advice from the group on, or just some ideas. So I work primarily with long-acting injectable medications here at the HIV clinic, and part of what I do is a lot of education, just to sort of reiterate what providers have already discussed with patients as they're starting therapy. And this one, sometimes, especially in this one case, I just feel like I just never know how much of the information is truly getting to the patient. And in this one case, it was with a patient that actually speaks Swahili, and is doesn't verbalize a lot anyway. And it felt like, and maybe this isn't the case, but what it felt like is that maybe some of the things that I was trying to explain or engage with the patient about education wise maybe weren't translating culturally or well from one language to another. And so I guess my question is, or just thought is, like, when you kind of get a sense and you're not getting a lot of feedback, are there tools to sort of use to try to gauge that a little bit better? I know you talked about some of them like reteaching and things like that, but then sometimes when you have like a translator on the language line and there's a lot of pausing and things in between, and a lot of information that's trying to be exchanged when you feel like maybe it's not translating well across a language? Like, how do you walk away feeling like you've done a decent job with the patient?
Yeah, that's a wonderful question and a scenario that probably most of us face on a regular basis. Before I answer that, would anyone would like to chime in maybe with a strategy that you've used before that has worked?
And I guess more specifically, are there scenarios where things don't translate culturally well or language wise from other languages to English, especially when we're involving like medical terminology and things like that?
Yeah, I can chime in. I would love for others to. I don't want to be the only one commenting on this, but um, my parents speak a different language than I do, actually. So my parents are Nubian from Northern Sudan. I speak Arabic and they speak the Nubian language. So when they speak together in Nubian, then I ask them to like translate it to me. They'll be like, "Oh, it's so hard to translate. There are no words in Arabic that equate this." And it frustrates me because I'm like, what were you talking about? And they're like, oh, they give me a watered down version of what they have been talking about. And like they could be laughing and the watered down version, like to me is lame. It's not really a joke or whatever. So there's a lot of stuff that gets lost in translation, and that's something that happens a lot. Yes, Marcy, it gets really like funny and frustrating at the same time. But I think it's important to understand that the effort by itself shows the patient that you care, right? The fact that you're actually trying your best to send them that message. And the fact that, Priscilla started this talk with, Dr. Priscilla started this talk with culture and then moved on to language, because language is just an expression of culture, right? So it's not, it's, whatever happens with language sometimes also can manifest in what happens in that culture. So it could be that the patient in their culture, they're pleasing, they want to please you, they want you to feel like they appreciate and understand what you're saying. So that could be the way that the silence itself could convey that I respect you and I appreciate you. So I think many times when I get to that point, I want to understand the patient, that the patient knows that I'm trying my best, even though something might get lost, because there's always something that gets lost in translation, but they know that this is safe and they can ask questions, and I'm going to try my best to find a way to answer their questions.
Anyone else would like to comment or share maybe a situation?
Hi, I'm new to this group. I'm from Children's. Um, I struggle with this too. We have a patient who is 11, who we've obviously been seeing for years, and their native language is Karen. And it seems like I say a lot of things, and the interpreter will say these things, and then the mom will have like a one word answer. And I really try to communicate with her, but I don't always feel like I'm I'm getting through. So it is a challenge. Some families are wonderful and the interaction goes well, but those ones that don't go well, yeah, those are the ones that you walk away thinking, gosh, what could I have done better? I don't have a great answer other than I think interpreters are just a godsend. I don't know what we would do without our interpreters. So I guess I can empathize with you, but I struggle with that too.
And sometimes I'm a case manager with NAP. I have a client who speaks French. She's from West Africa originally, and she understands some English. And there's times when I can communicate with her, and she can understand. It has to be very basic, but other times, a lot of times, I have to rely on language line. We call the phone line, and even in language widely spoken is French. There's still dialectal differences. The guy on the phone the person, the interpreter might be Quebecois. They could be European French. So there's different dialectal differences. So sometimes it's a little bit of a struggle. Or they might use some different terminology, things like that. So even it's not just obscure language, it's a very common language. I know in Spanish too. Some of my coworkers are bilingual and they might be Mexican and then they're speaking to a Cuban or a Puerto Rican, and there's those little subtle differences that can make a big difference. Sometimes you don't realize it. So,
Yeah, thank you all for sharing. Yeah, that's absolutely it happens. And the providing culturally competent care is no intent for us to learn about all the cultures and how everyone behaves, right? That would be impossible. And even though we cannot generalize one culture versus the other, right? We cannot assign those values. So it's really about what you just shared is being intentional in the care, making sure that you are being respectful of the patients. And even if when you have more challenging situations, that you are doing your best to listen and to ask. So one way you could say is do open and start with open-ended questions, right? So you mentioned your patient usually has a one-word answer, right? So ask what are what are the challenges right now, or how does that make you feel, right? Because sometimes it might not even be about that diagnosis, that situation. They might be also thinking about something else that they're just bringing. They're not having maybe a good day or something happened, right? So, how can you help them at that moment, at that time? So sometimes just taking a step back and just trying to understand what's happening in that situation in that moment before you dive into that specific. And again, I know this is easier said than done, especially with the limitations of, time and constraints, but just being mindful and being present and being honest with the patient, that goes really well. And I saw another people coming off camera. Thank you all. Would like to share something.
Hi, my name's Arvind, and I'm a physician trained in India, but in the US, I do mostly epi work. I'd like to add two things here, and I think one of them pertains to actually my wife's experience as a family care physician in Lexington, Nebraska, which, as you all know, is a very multicultural place. As a demographer, I find it really fascinating. It's the most diverse large town in Nebraska, town of more than 10,000 people in Nebraska, beats a lot of other cities across the country by a long shot. We're about 65%, 60% or so Hispanic, about 15% or so Somali, and rest is white. One thing that I've experienced, and of course, I'm from India, a new immigrant, moved here about 15, 20 years back or so. What I found is that obviously I'm not dealing with the patients, but the patients is a small town. Everybody knows everybody else. And my wife actually got a lot of, she was born and raised in Lincoln, Nebraska, tall white girl, accent, very, very Nebraskan, all of that. And so it gave her some amount of, I don't know how to put this, but without the patients, primarily because English was not their first language, and they're really concerned, extremely smart, extremely witted immigrants. I mean, if you've moved across from Somalia, bounced through a bunch of other countries, and then come to the United States, you're an incredibly competent person, right? So these people, just because they don't know English, they're really watching her like a hawk, or watching any doctor like a hawk, right? They're watching for these signs, for these subtle nonverbal signs. And so I found that it was, they're kind of watching you for signs of that you're kind of in our camp. And it sounds really weird to say, but just a personal decision from my wife that she was married to an Indian man uh, broke down a lot of boundaries with her Somali population. And she speaks fluent Spanish, and so she could really like interact a lot with her Guatemalan and with her Mexican patients who didn't speak any English. But it was the Indian piece with the Somali patients, not the other piece, just because we kind of know this piece about your personal life that sort of signals to us that you're kind of a good person. And it could be anything. It could be in your office, or it could be the way you If you see a Muslim person, it's the easiest thing in the world to say Assalamu alaikum. We often say Mazel Tov when we see someone who's Jewish and who's celebrating a festival. So, small little indicators, the fact that you would be culturally, those small cues, I think went a really long way. In my wife's case, it was her necklace. And the necklace, and to people who know, they could say, "Oh, hey, you're probably married to an Indian. That looks familiar, right?" And she got a lot of comments like that. So I think doesn't really mean being untrue to your own self. Obviously, we are who we are, and like someone very clearly pointed out, you cannot be proficient in all cultures, but just sort of non-verbally, I think, signaling to a patient that you might be the kind of person who is open and who's non-judgmental and who's like, I don't know. Maybe it's the art in your office. Maybe it's the small, subtle cues that you drop that are non-verbal. The way you treat women, the way you treat bystanders. I don't know, but I think as clinicians, that's probably really, really goes a really, really long way. And you're being assessed by someone who's a patient who, again, like I pointed out, I mean, first generation immigrants are incredibly smart. I mean, especially the Somali community, like what life experiences, So, like a lot of EQ people who really understand what's going on, and so they're watching you all the time. And I think that goes along. Just to add that.
Thank you so much, Aravind, about this comment. And I think just kind of trying to actionalize that, because you might not have a spouse or a family member or something that you put around there, but I think the real thing is that people feel that genuine cultural sensitivity versus performative cultural sensitivity. So if you're in front of a patient and you're trying to be genuine and humble and have that cultural humility and appreciate their background and value it and not give it, a negative value or a highly positive value even, they do feel that genuine approach. But if you're doing it in a performative way, so you could say that we practice cultural sensitivity, then they would feel it and that will turn them off. And like Arvind said, the patients are reading all those facial clues, like the way you sit, the way you're paying attention to them. Are you speaking to the phone, to the interpreter on the phone, or are you speaking to them and having that eye contact with them? And those little clues sometimes can go a very long way in building trust. So even though if they might not be saying much, and to them, that might be actually a way to respect you rather than a way to not, or the way that they're not understanding. I mean, my dad has been to multiple doctor's appointments lately, and he responds with a yes or no to the doctor. That's all usually it is. And I see the doctor struggling to get more information from him, and that's just him, just saying yes, thank you. That's his way of showing that he understands and he respects what the doctor is saying. So yeah, so I think that's cultural humility and understanding that not everywhere is going to respond the same way, even from the same community. It could be a Somali patient, and this Somali patient is very talkative, and then another Somali patient is just not that talkative. So there are nuances even within the certain culture, but I think the genuine interest shows through to patients usually.
Thank you so much, Nida, for adding that. You took the words out of my mouth. Absolutely agree with all that you say. I also wanted to say that, I've sort of practiced and lived in 3 countries now, including Africa, and then, of course, in India and the US. Uh, I think Americans do a really good job. Medicine is incredibly hierarchical, and doctors in most countries are really ivory tower. They're sitting there. In parts of India, the doctors don't even touch the patients because of a variety of other other messy situations in society. And so, almost always doctors sort of have that distance from the patients and tell the patient what to do. There's a lot of paternalism. We all know about it. We've read the theory. We've read the papers. The US is unique uh, in just the kind of remarkably egalitarian attitude that people have. The service sector in the United States is just has this sort of, it's sort of inbuilt the sense that we're all the same. You come here, you're somebody who's coming here for services, and we will treat you just the same as anyone else who's a paying customer, and we sort of like treat you. There is a remarkably egalitarian attitude. You don't judge people by the quality of their clothes or their accent, the way they speak English, the way they pronounce different words. I think Americans, the service sector, and especially doctors, they take a they really go take a lot of effort to really go there. So, I mean, I'm not saying obviously it's not perfect. Obviously, there's a lot of room for improvement. But I think in general, the sort of the American attitude, the sort of like, we'll take you, we'll meet you where you are, and we'll accept you for who you are, not who your father is or who your mother was or who, what your grandfather, which language your grandfather spoke, just who you are right now in the patient. It it's really good for these kind of conversations. And the fact that we are having this webinar and thinking about it really speaks very highly of the US medical establishment and the professional ethics here. So just to add that.
Thank you all for sharing. Anyone else would like to comment? I know we're reaching the top of the hour, but the conversation is really important and interesting. So before we wrap up, thank you all for sharing. Great ideas, suggestions, and yes, keep in mind that we should treat the patient, right? And it's individualized. So it's like Dr. Fudu mentioned, it's not only about the language, the culture, it's about the patient as a whole. So being mindful of that and being respectful and trustworthy goes a long way. Before we finish, I have two additional questions that I would love to hear from you and the poll everywhere. One thing that you've learned today that you plan to apply in your work, and it could be one of the strategies, maybe something during the discussion. If you could share that. Awareness of the importance of language barriers. Yes, I actually, it reminded me of one comment, I believe it was Susan who mentioned about sometimes your patient has limited English proficiency, but the relative, whoever is with that patient, speaks English. So it's sometimes easier for you to try and communicate with the relative and neglect the patient. So that's just another thing to keep in mind, right? It's about the patient, of being aware, including the family, but the patient should be the center, right? So that was a very important comment that was made. So yes, genuine effort, more inclusion in the teach back method, understanding body language and the nonverbal cues we talked about. And for interest of time, I have one more question, and I'll keep saving those. So thank you for. And then if you have any questions left, this is actually my last slide. I know it's the top of hour. We are staying on to continue the conversation. And I don't know if Daniel or Dr. Fudu or Jen have any announcements before we wrap up.
So no, we'll just see you again next month. This will hopefully resume next year. We haven't really decided exactly when the sessions and how, but we would love to see you in December because that will be the final wrap up of phase one of the sessions. But yeah, back to you, Priscilla, and we will remain available, as I mentioned in the chat, after the top of the hour.